Good afternoon. Welcome to Medical Grand Rounds. Good to see folks in person and good to see people online. We're doing the hybrid thing and probably going to do it forever. A lot of moving pieces, so we're trying to work it all out. But thanks everybody for joining us. I'm Bob Wachter. I'm chair of the Department of Medicine. The ground rules for those that are here: enjoy your lunch, and hopefully we'll have a little time for Q&A at the end. If you have questions online, just put them in the Q&A box. It is available. Closed captioning is available, as is CME. If you're interested in CME, for those online, the instructions will be available at the end. Today is a special Grand Rounds. This is a clinical problem-solving case with Gurpreet Dhaliwal. Folks have probably attended versions of this in the past. Gurpreet is a clinician educator in our department based at the VA and a professor of medicine, also the site director for the clerkship based at the San Francisco VA Medical Center. He is a world expert in medical diagnosis and in teaching clinical reasoning and has brought it to a high art. He's a member of the UCSF Academy of Medical Educators and our department's Council of Master Clinicians. He's won every teaching award that we have to give and teaching awards by other organizations as well. He's been a podcast guest on many different podcasts. He's been featured in the New York Times, and he's also a stellar human being. And so what we are going to do here is our clinical problem-solving case. While I think of it, by the way, next week is our first of the month COVID Grand Rounds, and it will be virtual only. So folks plan to attend online. One guest will be Paul Offit, who's really the top vaccine expert in the country, talking about boosters and vaccines in kids, boosters in everybody, et cetera, et cetera. And so we'll also spend some time on oral antivirals with a special focus on Paxlovid and how it's actually working and how to get it and all that kind of good stuff. So that'll be next Thursday. But for now, we're going to do a clinical problem-solving case, and let me thank Feng Sun, our chief resident, who prepared the case, and a mystery guest who will be the discussant. If I told you who it was, it would give away what kind of case it was, so I won't do that. Here are the ground rules. I think people probably know these. Our discussant is blinded to the case. He has not heard the case before, and our goal is to learn how an expert clinician thinks through the case. We always say not necessarily to get the case right. I know Gurpreet prides himself on trying to do that, but really the goal here is to see how he processes the information in real time. It's about the journey, not the outcome. And we'll have a few audience response questions for you as we go along. And I find these cases to be among the best learning experiences that we have, both for the clinical content, but really for the way our processors between our ears work or should work as we hear a case in real time. And also to emphasize, he's not heard the case and he's trying not only to diagnose and think about the case, but also to the fact that several hundred people are watching both here and online makes it particularly challenging. So this should be fun, at least for us, maybe not for you.
No, it's always fun. It's my favorite.
Any comments before we get started?
No, thinking about these cases, you think a little bit about it's like a chess match, sort of like what's the opening game, what's the middle game going to be, and the end game going to be, where you get to the diagnosis. And so I think you'll probably be like me. You're going through your footing in the early part, saying what's the issue we're trying to solve, and the middle game is the most fun, and the Tightwire app comes at the end.
It does. Okay, let's get started. 75-year-old woman with a history of Sjogren's syndrome presents with fatigue and back pain. 5 days earlier, she had chills, night sweats, body aches, and decreased appetite. 2 days earlier, she noted new severe lower thoracic back pain that she attributed to sleeping on an air mattress. 1 day prior to this presentation, she noted intermittent chest and epigastric pain, described as sharp, radiating to the back, and improving when she sat upright. Given difficulty walking due to the back pain, she presented to the emergency department. So let's start with an audience response question. I think the folks in Zoom world can do this with a poll that they have. For the folks that are here, I'll just ask you to raise your hands. Are you most concerned about acute coronary syndrome, acute pancreatitis, a vascular emergency, an infection, an autoimmune process, or malignancy? We'll give it a few seconds for online, and then I think Lakshmi will tell us the results. For the folks who are here, why don't you raise your hand for A, for B, pancreatitis, for C, a vascular emergency. Don't be shy. For D, an infection of some sort. All right, looks like about half of you. And E, an autoimmune process. Couple. And F, a malignancy. And we got a couple there too. Okay, and what did our online group say? We're waiting.
So most people voted for infection, about 44% of people, and then 17% are worried about a vascular emergency.
Okay, thank you. So let us turn to Gurpreet and see what he thinks.
No disagreement with the crowd there. I think all of those are reasonable considerations because there's a huge territory of disease here. We have chest, epigastric, back pain. If I focus on back pain, maybe because it was in bold and it's what happened first for those two reasons, often the most back pain that we contend with, regardless of people's past medical history and age, is going to be related to the musculoskeletal apparatus that's there or idiopathic. But I think there's some signal here that this may be more of the inflammatory variety, like we're hearing about night sweats and body aches and chills. And so that then changes your thinking a little bit. You can go through the three major categories that were discussed: infection, autoimmunity, and malignancy, and you can make direct ties to her Sjogren's syndrome. So for instance, the Sjogren's syndrome is treated with any immunosuppressive agent, and that increases the probability that there might be an infection in the back, discitis, osteomyelitis, epidural abscess. But it's also important to remember there's a lot of systemic diseases that present with back pain, but there's no metastases there. Subacute endocarditis is one of a classic example of that, where people have back pain, but it's more rheumatologic than it is metastatic infection. In the malignancy category, her age alone increases the probability that there might be a malignancy, although this is pretty acute. But it is worth noting that Sjogren's has a markedly elevated risk of lymphoma. It's quite staggering, almost 40x in certain tissues. So we could think about whether it's been brewing for a while, but now that's become manifest in the back or any of these other spots. And then with regards to autoimmune disease, it's tricky. She has an autoimmune disease, but it's not typical of Sjogren's, which is usually a disorder of exocrine glands that are affected by infiltrating lymphocytes, to have musculoskeletal manifestations, at least as its primary cause. There are times when Sjogren's can have more systemic effects, like Sjogren's can have a vasculitis, which might be manifesting in the back or the aorta or the pancreas, some of those organs that we mentioned. Or Sjogren's sometimes can cause metabolic abnormalities. For instance, it can cause an interstitial nephritis, and that might lead to some bone mineral density abnormalities through calcium and phosphorus. But all of those are fair game. I think the thing that I appreciated in that list more than anything else was not just thinking about the back, which we oftentimes do, but remembering that there's other retroperitoneal organs where serious inflammation can happen, and the pancreas and the aorta were two great examples of that.
So how do you think about the differential diagnosis in terms of the sort of confluence of probabilities versus can't miss?
Yeah.
Like when I hear chest pain radiating to the back, there's an immediate trigger for dissection or some vascular terribleness,
Yeah.
which would be like a can't miss, got to figure that out quickly. Whereas some of the other diseases are obviously you need to find them, but maybe not quite that urgent. How do you, because you're weighing both, you're weighing probabilities, but you're also weighing sort of the valence of the probabilities.
I think that the idea that we have these trigger words like chest pain radiating to the back, we learned that first with a strong association, the aortic dissection, but then that gets tempered over time by seeing how often that doesn't pan out, right?
Mhm.
That the worst headache of your life is not a subarachnoid hemorrhage, that chest pain radiating to the back is not an aortic dissection. And I don't think you ever lose the concern, but I definitely think it weakens the association unless maybe there's some other company it keeps.
Mhm.
Like that a chest pain radiating to the back has no other obvious explanation to it, or there's an ischemic phenomenon distal to it. Then all of a sudden it starts to take on that importance that maybe when I learned the association first, it had.
So you think this is some imprinting during medical school. When you hear that
For
thing,
sure.
it's forever stays with you, even though it may actually be not.
I mean, the coefficient on it isn't one. It's not,
Right,
right? So there's some
right,
value
right.
to it, but
Okay.
it's probably much less predictive than we first learned.
And then there was another sort of pearl here that may be worthless. Improve with sitting upright. Did that do anything for you, or you blew that off?
I didn't, there's some types of pain, for instance, pericarditis pain or pancreatitis pain that we have positionality to it. I don't know how diagnostic that is. I think sometimes people just find a way to make it more comfortable
Mhm.
if it works for them. So, for instance, pancreatitis is oftentimes better if people sit forward. So that might slightly raise that, but I would not be surprised if any diagnosis in the end just feels better if you change your position.
Mhm. So it really didn't move your probabilities very much hearing that.
Not much, especially given how important all the other ones were that I
Right.
was considering.
Right. Okay, great. Okay, so we learn more about her Sjogren's syndrome, diagnosed 9 years earlier after presenting with sickest symptoms and bilateral peripheral sensory polyneuropathy. She developed ITP 7 years ago, treated with prednisone and hydroxychloroquine. And prior workup, SSA positive, rheumatoid factor positive, and polyclonal gammopathy. She also had hypothyroidism, a left Bell's palsy, and osteoarthritis with bilateral total knee and a left total hip replacement. Review of systems, she had dry mouth, denied visuals, symptoms, dyspnea, cough, nausea, vomiting, diarrhea, dysuria, joint pain or rash, meds, hydroxychloroquine, levothyroxine. Social history, retired school teacher who lives in Florida, visiting family in California, no alcohol, tobacco, or drug use, no animal or outdoor exposures. Assume she's been outdoors, but that's a different issue. Family history, adopted, and 2 adult sons without chronic diseases. So does any of this help you with your differential? We learned more about her Sjogren's history and also this additional history of ITP.
Yeah, I think, and I'm sorry, the meds I want to see too, just before, or did we not mention them? Okay, yeah, the point about her being on an immunosuppressive medication, which was sort of front and center when we thought about inflammatory disease. Hydroxychloroquine is sort of like a mildly immunomodulatory, but it doesn't by itself sort of really predispose to a huge number of infections. So I'm back to thinking that she could have a run-of-the-mill infection, bacterial infection, for instance, but that this doesn't change that. I think what I'm more impressed of or reminded by is that how systemic a disease Sjogren's is. So even though we learned about it affecting exocrine glands and causing dry eye and dry mouth, it can be associated with vasculitis, neuropathy, interstitial nephritis, and it oftentimes has overlap with other autoimmune conditions. RA and it often travel together, sometimes just serologically, but sometimes RA and Sjogren's syndrome coexist. And then the autoimmune tendency that it might bring with it, like hypothyroidism there. But overall, other than knowing that, and the ITP I should mention, so she really has sort of an autoimmune diathesis to her. But overall, I don't think this radically changed the way I might have thought about this case if she hadn't had Sjogren's. And we still said this is a 75-year-old woman who had fairly acute back pain with inflammatory symptoms. I would still probably worry most about infection, then malignancy, and then autoimmunity, I think still is in my third position right now among those 3 cardinal categories of disease. And I'm not, by the way, in real practice, I bet you the most common explanation for this would be that the infections are not one of the serious ones I mentioned, but it's a run-of-the-mill viral infection, anything from COVID to the flu to the cold that exacerbates musculoskeletal ailments. So low back pain oftentimes shows up, or aches and pains show up in viral syndromes, NOS.
And we know that she's got bad arthritis already.
So that can be exacerbated in that way. We don't know whether it's in the back or not, but it's a reasonable chance if she has it in her hips.
Does the fact that she's had 3 joint replacements change your thinking about her at all?
The only thing I might think about is that is a large number of joint replacements and whether the underlying diagnosis was accurate, for instance, like was that all OA or was that another autoimmune condition or rheumatoid arthritis? The rheumatoid arthritis itself wouldn't substantially change the way I think about her back pain per se, but I may wonder that.
And hearing the ITP bleeding into her back, pericardium wasn't on anybody's original list. Does that now enter your list, or you're not going there?
I think that ITP, as its behaviors, in some people, it's sort of a chronic, persistent problem, and in many people, it's a self-limited disease. And I'm taking from this that it's self-limited. I think I'll need the something on physical exam that shows ecchymoses or bleeding elsewhere, or of course the CBC to elevate that. And then I'd have to say, oftentimes blood in the back and the retroperitoneum. We sometimes stumble upon it more because of anemia than we do symptoms that the patient has, like pain per se, unless it's coming from an organ like the aorta.
Okay. And when you said, made you wonder a little bit about the diagnosis of osteoarthritis, are you saying, does Sjogren do joints, or are you saying that it sometimes travels with RA and RA does joints?
RA does joints and it travels with RA. I don't know how much primary Sjogren's arthritis is or how destructive it is to this nature. I'm sure it gives arthralgias. I don't know how much it gives erosive arthritis and to the degree with which it replaces a joint, whereas RA certainly can do that.
Okay. All right, let us go on. Physical exam, when she came to the ED, we have things helpfully highlighted in blue in case you didn't remember what the normal blood pressure was. Temperature 36.5, blood pressure 67/43, rapidly came up without intervention. Tachycardic 128, respiratory rate 22, 96% saturated on 2 liters. tired and anxious appearing, dry mucous membranes, normal conjunctiva, no lymphadenopathy, tachycardic, soft systolic murmur, no pericardial sounds noted. Normal work of breathing, trace bibasal crackles, abdomen mild tenderness to palpation diffusely, no rebound guarding, extremities warm and well perfused, no edema, neuro, chronic left facial droop, strength intact, decreased sensational light touch at feet, midline and paraspinal tenderness to palpation at lower T-spine, sounds like where she was complaining of pain. No pain with range of motion of her knees and hips, and no rash or ecchymoses. And I don't know if you want to comment on that before we go to the labs.
Just maybe, she comes with a very scary low blood pressure, sort of resolves partially on its own, but I think that's cold comfort. Oftentimes you learn that when there's a transient improvement, like where there's smoke, there's fire, and it may not stay that well. We didn't do anything and it raised, unless it was a measurement error. You have to wonder if the process that's responsible for this, whether it's sepsis, adrenal insufficiency, med effect is going to rear its head again, and the tachycardia and her tachypnea tells you that there's a good chance it's not just an error that's there. I think the other things that stand out is just trying to catalog other organs where Sjogren's can affect itself. I neglected to mention the lungs. Even the lungs, it's basically where lymphocytes can go and cause trouble, and it can cause a lymphocytic interstitial pneumonitis there. But I'm more concerned if that might reflect an infection that she might have at this period of time. And then she came with chest pain and epigastric pain, and now she has tenderness there. So we can't just focus ourselves on the low back like we were, or the thoracic back like we were before, and we have to consider serious intra-abdominal processes that may be folding. One thing that works in our favor is that she's not on prednisone. It is worth emphasizing that had she been on prednisone, manifestations may have been blunted, and there's an increased risk of something like a perforation. But the diffuse tenderness palpation makes me think again about those organs we mentioned, like the pancreas, for instance, being involved.
So the prednisone, this is something we also learned in med school, just want to see in your experience whether it holds up. Someone on a reasonable dose of prednisone and has an acute abdominal emergency, do you find that you can push on their belly and they're fine and smiling at you the way mythically the story is told?
Mythically, the story is told. I think that one has validity. I read once an article years ago that the person mentioned, they said, they were telling their story of having missed it, and they said, you too will miss this once. But it sounds silly, and you say, well, once I hear about it, I certainly won't miss it. But I've done that at least on one occasion. I do have to counterweight that against the hundreds of many patients you see on prednisone whose exams are exactly as you would predict. So it probably goes in the bucket of the worst headache of your life, that there's some coefficient on it, but it's not that high. But the pitfall is worth knowing about.
Yeah, I mean, exactly. So I have a memorable case from my residency where someone who had a perf and was smiling and doing fine was on 40 prednisone, and that sticks with you forever. And it's probably the only time I've seen it. But it's like, okay, this can.
It moves from the realm.
It can happen, right?
We know mythical to at least it's been seen.
Yes, it has been seen. Okay. She's got a murmur. Obviously, she's tachycardic and hyperdynamic, so it may be nothing. Does Sjogren's do anything to the valves in terms of risk of giving you substrate for endocarditis, let's say?
I'm going to be diplomatic and say not that I know. Okay. I'm sure there's a possibility. For instance, in autoimmune conditions, is it possible she might have a predilection for like a Libman-Sachs endocarditis, something along those lines? The way we might think of it in SLE, that's just conjecture, and I'm sort of thinking analogically, but I don't know about its involvement of the heart like those other organs I mentioned.
Okay. I forgot whether she complained she had pain in her joints, but on exam she's got no pain with range of motion. I assume that's reassuring in terms of the joints being infected. She's got hardware in the joints,
because that could be a source or it could be a place where an infection lands. But right now we are trying to figure out sort of the focus of disease. Like, is the back where it's at, or is the back an epiphenomenon? The abdomen is where the action's at, or are we all fooled and the heart is there? This low blood pressure and tachycardia makes you wonder, is there going to be a pericardial effusion, or is there going to be a valvulopathy that we're missing?
And are you trying to figure out, is there one source of infection, for example, in the abdomen that's causing belly pain and back pain? Or does this exam and this entire gestalt make you think about a multifocal infection.
Not yet. I would be, if you, in the end, we found out that there's like a perf duodenal ulcer, just as an example.
Yeah.
I think that would be a completely fine explanation for the whole picture. So I'm not trying to find something metastatic or multifocal at this
Yeah,
time.
so not as if she had a hot knee and her back hurt
Right.
and she had crackles where you might be saying, I got to figure out what's sending infection all over the body.
Because the challenge is there's a million abnormalities here, but they're all mild, right? It's like
Mhm.
chasing after a sodium of 131. Like the chance that that's going to be diagnostic is slim. The chance of mild tenderness palpation or mild crackles or a slight, he shouldn't have slight tachycardia, but those, they're not strong signals yet, but I'm tracking them.
Okay.
And they may become something.
Okay, and I assume the fact that she's afebrile here in the ED, so single check doesn't
Yeah, that's
dissuade you very
cold
much.
comfort. Yeah.
Cold. No pun intended, cold
Yeah,
comfort. Okay, let's go on to some labs. So see white count of 2.6 with a very low absolute lymph count, hemoglobin of 11, platelets are normal. There are her electrolytes, CO2 14, BUN 48, creatinine 4.2, and a gap of 19, no known history of chronic kidney disease. LFT's fine, albumin low. Lactate 7, SED rate over 100. CRP 417, troponin is negative, BNP 502. INR is elevated, fibrinogen 876, smear is normal without schistocytes. UA protein 100, 11 to 20 white cells, less than 3 red cells. COVID negative, blood and urine cultures taken but pending.
Okay.
And so I assume there's a fair amount here to go through.
There's a lot to go through here. I think a lot of this confirms our sense that she's inflamed, but I think the things that surprised me were the acute kidney injury. Thank you very much for providing the anion gap calculation so I don't have to do math in front of a crowd. Very grateful for that. And the other thing I'll just say that I'm struck by is the albumin of 1.7. Even if she, in this 5-day illness, for that albumin to have plummeted, that's fast for what might be an acute phase reactant. Had you told me it was 2.5.
But you don't buy that she's got this chronic inflammatory thing for years and that's good enough to give her a low albumin.
Yeah, I don't think it's characteristics of Sjogren's to do that. And again, she hasn't required any heavy duty immunosuppression to signal that it's, even though she has some end organ dysfunction like the neuropathy. So I might track that as well. There's 1+ protein, but sometimes we have to figure out how much protein that is with a direct ratio or 24 hours. So there may be more than meets the eye there. But just going through this, I think the biggest ticket issue is that her kidney is injured. Now this could be hemodynamic because she's rolling in hypotensive. This could be kidney related disease. Sjogren's, I mentioned one manifestation, which is caused an interstitial nephritis. Essentially the lymphocytes are going to the same, as they go into other organs, infiltrate the interstitium. It also has an association with glomerulonephritis, so a GN is possible in that state. And then we do have to make sure there isn't a post-obstructive phenomenon that's happening as well. For instance, the Sjogren's has led to lymphoma, and she has a lot of retroperitoneal lymph nodes that are encasing the ureter. So all those are in play. The active UA makes me think that the kidney is going to be responsible. This could be something as simple as this is a UTI. We had no dysuria up front, but remember we had back pain, epigastric pain, pyuria, hypotension. Certainly it's a reasonable case to at least consider. The other thing that strikes me here, though, when with that acute kidney injury is with that low bicarb, another phenomenon that happens in Sjogren's syndrome is a renal tubular acidosis from the infiltration there. And so I'm going to wonder if that's going on. I hope someone better than me in math will help figure out if we get more urine electrolytes. But just thinking about how much kidney injury is happening here, that shouldn't be the cause of her pain, though. When the kidney is injured in this way, it doesn't hurt. So we still have to figure out why she has her pain in her thoracic spine.
Is your inclination seeing the white cells could be pyelo, could be interstitial nephritis? Is it also could just be ATN that she's septic and?
Yeah, ATN's fair game as well. We don't, the casts aren't there, but those are they're nice when they're present. You need more context. And if we call this sepsis, and what she has is, lymphopenia from sepsis and AKI from sepsis, ATN, that'd be a very reasonable. That lactate is 7.5 might drive you in that direction to think that's what's going on. We don't have a source, so if we don't have the urine here, we're going to have to use imaging, chest X-ray or abdominal imaging to figure out where that source is. And I'll just add one other thing. Sjogren's, I don't think typically causes cytopenias like this. So that's a pretty profound apoptotic lymphocyte. Normally the lymphocytes are reduced from things like sepsis or drugs or viral infections. And so those things should be kept in mind. And of course, HIV testing would be warranted anyways because of how sick she is, but this would be another reason.
So, yeah, so what do you do with that? So it's an awfully low count just for sepsis. She's not on a drug that explains it that I know of.
Right.
So where does it land you?
I think you expand the infection she might be susceptible for, almost starting to lean a little bit on the playbook we may know best from HIV. I think examination of the smear here is important because the other possibility is that lymphopenia reflects something going on in the marrow. I alluded to earlier about the risk of lymphoma, but maybe this is all unrelated to her Sjogren's and she has leukemia that's unfolding here. And so you really have to examine the smear to make sure there's no atypical forms and blasts. I think that would be a high priority. There's nothing to fix, like we don't give GM-CSF right away when we see this, or a colony stimulating factor. And you might say that in the course of her workup, she'll get a number of these viral serologies, but they take some time to come back. They're not actionable on day 0.
Okay. How comforted are you that someone does not have marrow infiltration when one of their 3 cell lines is fine?
Not reassured. I think you don't need to have pancytopenia, and even all of hers essentially, even her platelet count is on the low-ish side. So you could open up a whole nother line of reasoning here and say, what are the causes of pancytopenia, right? She's been immune before in the past. Is it possible that she's having an autoimmune hemolytic anemia? This is the beginning of autoimmune thrombocytopenia. Possible. I think the trajectory we need to know.
And you commented right at the beginning about the albumin of 1.7. So what did that do for you? And when you saw that, like, what did that trigger?
Well, either she's been sicker for a much longer time than we think. There's a nephrotic syndrome unfolding that we're not beholden to from that 1+ protein that we'll find out. It is conceivable that she's very malnourished, but I don't have a reason. There's no history behind it. You know, Sjogren's sometimes affects the dentition in very severe ways and limits people's food intake, but I don't see the match between that and the history that we had to think that way.
Okay.
So maybe
I assume
I'm open to it being like a very severe acute negative phase reactant, and it's just plummeted.
Okay.
It just strikes me about a unit too big.
So you're still, I mean, you're still sort of in the ballpark. This could all just be she's septic and she's got septic shock when she came in, and she's got ATN and she's got a lactate, and then it's on the background of some process that's maybe just her Sjogren's worse than we think.
Well, I'm not necessarily making her Sjogren's responsible for it right now. Maybe that Sjogren's is in the background. I don't have an easy way right now to blame her Sjogren's for the sepsis. So I'm looking for a source of sepsis. I'm trying to catalog if maybe Sjogren's is flaring. As I mentioned earlier, one of its severe manifestations is when it has a vasculitic form, but I haven't seen that yet unless the kidney is the first manifestation of it.
Okay. Okay, a few more tests come back. She has an ECG, sinus tachy with diffuse PR depressions and ST elevations.
Okay. I think I can see that little bit of wavy Bayform. I'll take your word for it.
Yeah. I'm taking fungi, so
we trust.
We're going to trust. And a CT of everything, and we'll highlight a couple of, so no acute aortic syndrome. There's circumferential pericardial thickening, shown nicely by the arrows.
Appreciate that.
Vascular thickening of thoracic aorta, some adenopathy, enlargement of and surrounding fat stranding of pancreatic tail, diffuse heterogeneous arterial enhancement of the kidneys, more arrows, and symmetrical presacral soft tissue thickening. So sort of a few different organs are thick.
I see the thickness again. In some ways, you're really trying to figure out, it would have been nice, every one of those organs, you may have a way to think about, you know, what causes a pericardial effusion or pericarditis, what causes aortopathies, what causes lymphadenopathy. Pancreas, I can't tell if that's substantial or not. But one of the things, the whole process, when there's multiple organs involved, we're again trying to pin it on what type of or category of disease might be responsible. If I put aside, for instance, and I think I'm going to do this for a second, the acuity of this thing, which sounds like coming out of the gates like a wildly inflammatory syndrome, and I saw a lot of thick organs, and wispy organs on imaging, I might ask myself not so much what is the category of disease this is, but what's infiltrating those organs, like what things can get into organs. And we sometimes talk about them in the infiltrative disorders. Sometimes it gets to be a very narrow list. People will say like amyloid, sarcoid, and hemochromatosis, but it's quite emblematic of the type of things that can infiltrate organs. Like sometimes you'll have cells that do this, like eosinophils or histiocytes, like a histiocytic syndrome, for instance. Sometimes you'll have just pure molecules, like amyloid molecules will do it. Sarcoid is a granulomatous phenomenon, but slow-growing malignancies often do that same way. They'll have that same sort of infiltrative pattern to them. IgG4 disease, again, we've talked about her sort of immune tendency that she has. So is that another autoimmune disease that she has?
What is that?
Oh, IgG4 related disease, sorry. So IgG4 related disease was discovered probably like, I don't know, 10, 15 years ago, first reported in Japan, and then we started to recognize that IgG4 immunoblasts, plasma cells, infiltrate these organs where we'd see thickening, and they would be in organs like the pancreas and the aorta and the pericardium and virtually all other, the thyroid's another gland, and all sorts of other organs where we thought they were attributed to other things. Like people would be misreported as having a syphilitic aortitis because their RPR was positive, and then years later we went back and said, whoops, like that was IgG4 related disease. So just adding it onto the list of infiltrative disorders.
And for any of these things, could they be manifestations of Sjogren's, or is it something, did she not have Sjogren's? I mean, as you
No, it's a good point.
can Sjogren's do all this? And
you can go back, it's a great point. Sjogren's is a lymphocytic interstitial, or sorry, lymphocytes infiltrating tissues. Of all the ones I mentioned, the only one that mimics that pattern, I think, is IgG4 related disease. It even has a tendency for some of the same organs, like salivary glands or lymph nodes, et cetera. The one problem, or at least concern I have, is the explosiveness of this illness. This is like a 4 or 5 day illness, and IgG4 related disease, and Sjogren's, for what it's worth, also tends to be indolent, although I'm sure all these diseases can accelerate. So as I look at this pattern of multiple organs being involved, and I'm trying to take stock of the type of cells that might go there quickly, I think a malignancy like lymphoma could spread in all those places quickly. I think plasma cell, like IgG4 related disease, would be possible. It's not a bad pattern either for the category of diseases called histiocytosis, which are histiocytes or tissue-based cells that do it, but they are often very slow and indolent, but they do affect the pancreas, the retroperitoneum, the kidney. So it's just another category of diseases I'm tracking.
yeah, that's great. I just want to point out to people, I mean, just how fantastic this is to be sort of thinking through what can now cause this, and is it one disorder that for some reason has an explosive phase, which probably has a differential? Like, as you said, some of these things don't really, they just are indolent. And are there any that actually are indolent and then transform in some ways? Or is this two things? Is this, whatever this thing was, she's septic now, maybe because that thing predisposed her to it, or she's just unlucky?
Yeah.
So are in the differential of the things that could be indolent and then explode, is there anything?
I think lymphoma is a great example of one that might take an indolent character, and then all of a sudden, lymphoma in its worst forms is oftentimes a mimic of sepsis. And so that's one I think. IgG4, I think, is not, but I don't want to discount it yet because it's such a good replacement diagnosis for Sjogren's, because they're both lymphocytic infiltrative disorders, and they have these same similar overlap in organs that they. And
would it predispose her to infection in a way that you felt that Sjogren's wouldn't necessarily?
I don't think IgG4 makes you, I don't think it's immunocompromising. When you have to do it almost by tissue biopsy, about 50% of patients have a low IgG4 only, but I don't conceptualize them as being immunocompromised.
All right. Sounds IgG infectious.
Yeah, maybe.
To me, what do I know? All right. All right, let's hear some more. Great.
Yeah.
And you didn't make much of the cardiogram.
Well, just only because I assumed that was going to be pericarditis, and then now the imaging confirmed that the pericardium is involved.
So it just confirms there's something going on in the pericardium, but there's something going on in a lot of places.
A lot of places, precisely. Otherwise, we could go through, that's often idiopathic, could be viral, mycobacterial, malignant, uremic. She has acute kidney injury. Some autoimmune diseases, again, less, I should have brushed up on my Sjogren's before this. SLE is sort of the headliner for affecting the pericardium.
Why don't you go off for 5 minutes, read about Sjogren's?
I would love, I would love nothing more than a chance at
I think you're doing okay.
All right, we'll give it a go.
All right, so let's go on. Initial clinical course. She received IV fluids, blood pressure stabilized, heart rate improved, downtrending lactate, started on Vanco and Piptazo. 2 out of 2 blood cultures positive for strep, later strep pneumonia. Antibiotics narrowed to Vanco and ceftriaxone. additional studies completed to evaluate what was they were concerned about multifocal infection, TD poor quality, left ventricular ejection preserved, mild to moderate TR, no veggies, small pericardial infusion, bilateral knee arthrocenteses, 87 and 95,000 white cells with predominant polys, fair number of red cells, no crystals, no organisms, MRI spine pending.
I just want to emphasize those are prosthetic joints.
Those are
correct?
prosthetic joints,
Okay.
yes. So what do you make of that?
No, only because oftentimes the degree it's all hardware in there, so the degree of inflammation is, I think, in general, sort of more muted. And we have there's a different criteria. Native joints when they're infected is an emergency, so it's an absolute emergency. We have to wash it out and do everything we can to restore that function. Oftentimes when you see orthopedics and they're dealing with PJI, which is a prosthetic joint infection, it's not an emergency because there's no preservation of the joint. It is an infection control issue where the joint is going to have to come out almost no matter what, under all circumstances. We do want to make sure it's not seeding other places in the body. So just differentiating between the septic native joint and a prosthetic joint infection.
But do you have any doubt that these are infected joints?
Those numbers are very hard to not call infected, even though the gram stain is negative. I think you'd have to treat it. You sometimes will see stratospherically high numbers like this that are neutrophilic with crystalline arthropathies, but in this case, I don't think crystalline arthropathies precipitate in prosthetic joints,
Yeah.
and there were none seen there. So I think you have to work under the assumption that the strep that's in her blood has landed in those prostheses.
But probably not primary there. That's just a site.
I think it's a site. I don't think it's a common cause of primary joint infection.
Right. Okay. C3, C4 low. ANA plus 1 to 640 diffuse, SSA positive, double-stranded DNA positive, antibodies to SSB, RNP, Smith negative. Rheumatoid factor high, anti-CCP negative, quantitative serum immunoglobulins, IgG elevated, IgE mildly elevated, IgA and IgM normal. So let's ask you folks the questions we get toward the end. What steps might you consider at this point? Lumbar puncture, TEE, whole body PET CT, salivary gland biopsy, renal biopsy, high dose steroids. We're going off and reading a little more about Sjogren's.
I would love that option.
Let's just go through folks here while people answer online. Anybody want LP?
The MRI is pending, correct?
MRI is pending. Just one. We're going to force you to do value-based care here. TEE. Anybody want a TEE? We've got a few votes for TEE. Whole body PET CT. We've got a vote for that. An LDH, interesting. Salivary gland biopsy. Nobody wants that. Renal biopsy. Few votes for that. High dose steroids. We got a vote for high dose steroids. Okay. What do we?
So the
Fine, from
audience
Zoom world.
mostly wants a renal biopsy, 38%, followed by TEE at 29%.
Okay.
Yeah, I can understand both of them. The TEE, because this is a high-grade bacteremia that's landing in a lot of places. So to reject the endocarditis hypothesis, which pneumococcus can do, it's not as characteristic. One other thing, by the way, at least to our point, we haven't found where the pneumococcus is coming from. There's no infiltrate document. There's some RALs on exam, but there's no X-ray that tells us there was a pneumonia. There's no signs of meningitis to make us think this came from the meninges. So where exactly, or where the portal of entry was, it was probably through the lungs, but why it never set up shop there and went right to the bloodstream is worthy of considering. That does happen sometimes in people who are functionally asplenic. So the complete absence of splenic function allows for just a rapid bacteremia that oftentimes unfolds before the organ-based manifestation is there, making me wonder a little bit about her immune state. And then the renal biopsy, I agree. I think you'd do the renal biopsy if you were saying, this is not sepsis, like she is not septic, but with bacteria streaming through the bloodstream, it'd be really hard in this moment to say that I'm rejecting ATN. And I think that this is a vasculitic process. Like she has an autoimmune tendency in Sjogren's, and now she has either the vasculitis of Sjogren's or she has another vasculopathy, autoimmune vasculopathy, and it's a GN, and the low complement, maybe think about that. But a complement could be consumed by this infection as well. So I don't know honestly how you'd adjudicate between the two of them. Because there are low complement GNs, we talk about SLE, SBE, shunt nephritis, there's a long list of them, but in the setting of infection, and ANA being positive oftentimes travels commonly with Sjogren's as well. So I don't know if that's even reason yet to shift your thinking from saying she had Sjogren's to saying maybe we were sitting at Sjogren's as a working diagnosis, but this is lupus. that she has instead. With
And are
that-
these supportive? You gave a whole bunch of alternative diagnoses of things that can infiltrate multiple organs. Are any of these supportive of that, or
I don't
not
think,
particularly
especially with the
helpful?
double-stranded DNA, which maps on more specifically to lupus, I don't think any of them reliably do this. RF can be up in a lot of things like cryoglobulinemia, endocarditis, hepatitis. So that's sort of a non-specific finding. And the anti-CCP helps us say it probably isn't RA that was affecting her joints. I guess with the pericardial disease, the renal disease, the cytopenias like lymphopenia, the having to entertain the possibility that this is lupus, that this is sort of an explosive form of lupus that is unfolded, either lupus itself or some complication we're missing like antiphospholipid syndrome, starts to become more tenable. Just like Sjogren's can travel with RA, and now we're going to reject that Sjogren's can travel with SLE, an overlap-like condition. And that may be a better explanation for how she got so sick and how she's immunocompromised. Because SLE, I think of as a much more immunocompromising condition than the Sjogren's disease.
And the IgG4 entity you described before, are there any tests for that that are
No,
helpful?
but as 50% of people have a low level, but you really have
Low
to do
level
it by
of what?
IgG4.
Oh,
You'll be
serious.
deficient, yeah. Oh, no, sorry, scratch that. You'll be elevated. But the real diagnosis is made in biopsying affected tissue. And you'll see IgG4 staining, some infiltrating eosinophils, and this sort of, I think it's a whirling fibroproliferative pattern. So there's a specific histology that you need to see in order to make it. There's no blood test for it.
Okay. Okay, so you went through what you thought were reasonable next tests. So we got some outside records from the primary rheumatologist. 3 years earlier, she was seen by GI for incidentally elevated LFTs, viral studies negative liver biopsy, drugs versus autoimmune hepatitis versus PBC, ERCP without evidence of malignancy. You see the LFTs there. Serum workup at that time, notable for an ANA 1 to 80, homogeneous. Serum IgG4, 393, upper limit of normal is 86. She was treated with azathioprine and prednisone for a year.
Okay. So I think the case for lupus is still reasonably strong here. Even lupus has, the old name for this was lupus hepatitis, but now we'd say it's autoimmune hepatitis. That's a manifestation of it. I will say IgG4 related disease also has a cholangiopathy that's associated with it and can also affect the liver. So while the distribution of organs is characteristic of IgG4, the explosiveness of what's happening here, if not the infection, I still think makes me start to wonder, has there been underlying SLE all the while?
I guess the question I would have is why do you still feel like I've got to explain the explosiveness now that you have pneumococcus in her blood?
Yeah, good point. I should take that back. You're right. Now that I think I was holding that idea until I found an explanation, but now that there is pneumococcus, I think I can sort of say maybe something was in the background the whole time. I guess the other parts I'm struggling with, like, is the kidney injured by the infection or is the kidney injured by the underlying disease? And if that happens so quickly, I will say that albumin 1.7 now makes me think that this thing was brewing for a longer period of time. But the pneumococcus, if it didn't cause a massive acute phase reactant, then perhaps the SLE or IgG4 related disease or Sjogren's in the background is responsible for that.
Okay. It's a sad outcome. During induction of anesthesia for her spine MRI, she had VT, hypotension, she arrested, CRT started for worsening oliguria, bilateral knee washout, worsening hypotension, lactic acidosis, antibiotics broadened, worsening multi-organ failure, more meds added, CT notable for periapical disease in her mouth, and at hospital day 7, transitioned to comfort care, and she passed away, unfortunately. What do you think she had?
So I think here are the things I'm trying to coordinate, which is that she got pneumococcus. So why did she get a pneumococcal bacteremia? And then she had a pre-existing disease, and what was that disease? So I think the candidates for the underlying disease that she had in the past, just in my mind, is yes, she had Sjogren's syndrome. Yes, she had, I shouldn't say yes, she had Sjogren's syndrome, she had SLE, or she might have had a mimic of one of those, and IgG4 related disease is a fairly good mimic of Sjogren's. The two overlap in terms of the different organs that they infiltrate, even the histology. If you do a salivary gland biopsy, for instance, you'll find lymphocytes and plasmacytes in both places. The fact that she got pneumococcus, I think, is influencing me a bit, along with that pattern of disease organs that are involved, say the pericardium, pericardium, the aorta, the kidneys, and the pancreas, that of all those three diseases I mentioned, IgG4 has the most predilection to sort of infiltrate those organs. And then the last, and this is conjecture rather than fact, so you should probably strike this from the record, is I'm trying to think of which of those diseases would make her susceptible to pneumococcal disease. And my thinking would be that an immunoglobulin disorder would be more likely to render her susceptible to that than the hypocomplementemia. We learned, for instance, in SLE, sometimes there's an increased risk of meningococcemia because of terminal complement deficiencies that might travel together. So putting all those things together, I might say that perhaps she did have pneumococcal sepsis, and the underlying condition that she's had all along, and the thing that maybe was even permissive for this final event was IgG4 related disease. And that's how I might put it together.
Got to find harder cases. Clinical diagnosis at the time of death, presumed IgG4 related disease with acquired complement deficiency caused by and staph pneumobacteremia, complicated by staph pneumobacteremia and septic shock, likely from this oral source. And the constellation of findings were aortitis, presacral soft tissue thickening, hypocomplementemia, elevated serum IgG4 and IgE. And then she went on to have an autopsy that showed systemic IgG4 related disease affecting the meninges. You can read all of these organs here, basically every organ that she had, with functional immunosuppression complicated by pneumococcal bacteremia, pericarditis, extension of the pleural cavity, septic shock, and multi-organ system failure. This is the point where you can applaud if you'd like.
Thank you. Thank you for coming.
So we have a mystery discussant who's no longer a mystery. Mike Tomashow is here. Now, this will be a tour de force of hybrid conferences because Mike is virtual. So we're going to try to see if we can pull this off.
You had him for a second.
I did.
Yeah, you got it.
I'm pressing the layout button.
He is pressing it.
Oh, see him up there? Mike, are you there?
Yes, can you hear me?
Wow, unbelievable.
Good to see you, Mike.
Okay. Well, thank you.
I'll go advance the slides.
Great. Thanks so much for inviting me and for discussing this case that I was involved in. It really just was amazing, Dr. Dhaliwal, to hear you think through this case in real time. And I just want to just say as a reflection before I get into the slides that you know the patient's sons were aware that and were agreeable to us discussing this case, and were actually very enthusiastic that we were going to teach others about what happened to their mom, given that she was a teacher for her whole life. Okay, so IgG4 related disease, as Dr. Dhaliwal mentioned, is an insidious and progressive systemic immune-mediated disease manifesting as fibroinflammatory tumefactive lesions. It was not recognized as a distinct disease until 2003. On the right here is a list of diseases, including Rydell's thyroiditis, McCulloch syndrome, Ormond's disease, which were previously thought to be distinct diseases, but are now recognized to fall within the spectrum of IgG4 based on common histopathologic features. So due to a lack of familiarity with IgG4 disease, it's likely that a substantial percentage of patients remain undiagnosed. And so the true global incidence and prevalence are unknown. Interestingly, recent research suggests that the IgG4 antibody is actually not pathogenic, but rather is likely an anti-inflammatory epiphenomenon. Next slide, please. So as I mentioned on the last slide, the epi is poorly understood. That being said, the typical patient is middle-aged, between 50 and 70 years old, more likely to be male. Although most cohorts are out of Japan, where the disease was first recognized, IgG4 has been described in nearly all racial and ethnic groups. Clinically, patients present with tumor-like lesions in at least one organ. Sometimes this can be detected on exam, such as with lacrimal gland swelling or thyroid enlargement, but often it's picked up incidentally on imaging. Some patients have organ-specific symptoms, such as dry eyes or dry mouth, cough or abdominal pain. And a history of allergy or asthma is relatively common. It's seen in about a third of patients. Interestingly, this subset of patients tends to respond very well to treatment. Fever is rare. A minority of patients have subacute weight loss. And in general, patients really don't present with acute fulminant illness, like in this case. And so such a presentation should make you consider alternative diagnoses. Patients in general tend to be very steroid responsive, and in fact, a lack of response to high dose steroids, so something in the order of like 30 to 60 milligrams a day, would argue against the disease. Next slide, please. So IgG4 can affect virtually any organ, as Dr. Dhaliwal mentioned. That being said, it has a predilection for certain organs more than others, as shown in this diagram. In general, lacrimal and major salivary gland enlargement, type 1 autoimmune pancreatitis, and retroperitoneal fibrosis are the most common manifestations. Neurologic disease, including hypophysitis and pachymeningitis, as well as thyroiditis and aortitis, are infrequent. Next slide. So let's say you're evaluating a patient where IgG4 ends up in the differential diagnosis, either by symptoms, exam findings, or incidental imaging. So here are some studies that can aid in arriving at the diagnosis. So as I mentioned earlier, a subset of patients have a history of atopy. And in line with this, peripheral eosinophilia is seen in 1/3 of patients, and it's typically mildly elevated. Strikingly elevated eosinophilia should really lead you away from IgG4 as a diagnosis. IgG4 is not a highly inflammatory disease, like I mentioned, and recall that fever is atypical. Typically, the sedimentation rate is elevated, whereas the CRP is normal. This discrepancy, thought due to the ESR being driven by circulating immunoglobulins. CRP is elevated in only about 1/4 of patients. Hypophosphatemia is common, and it's seen in about 40% of patients and is usually a sign that the kidneys are involved. The mechanism for this is not clear, but it may be due to IgG1 activation of the classical pathway. Elevated serum IgG4 is not enough to make the diagnosis. 75 to 90% will have an elevated level. But in general, the absolute level of IgG4 at diagnosis is less important than the trend in monitoring response to treatment. Elevated IgE, as in this case, is very common. It affects 60% of patients, and it's often striking in the thousands. While an ANA and a rheumatoid factor can be seen in about 1/3 of patients, ANA subserologies and specific autoantibody testing for ANCA-associated vasculitis or cryoglobulins are generally negative. So in this case, our thought was that the double-stranded DNA was probably associated with true primary Sjogren's that she also had concurrently, rather than related to an autoimmune pathology due from IgG4 disease. So cross-sectional imaging with CT or MRI is very helpful to identify organ enlargement, aortitis, lymphadenopathy, and some practitioners will get a pan CT scan or a PET scan at the time of diagnosis to assess extent of disease. Next slide. So to make the diagnosis, you almost always need tissue to assess for typical histopathologic features. Lymphoplasmacytic infiltrate is a hallmark of the disease, which simply means that there's an abundance of lymphocytes, such as T cells and plasma cells on biopsy. If you do an IgG4 stain, the majority of IgG expressing cells are IgG4 positive, as shown with this immunoperoxidase staining on the lower right panel. Storiform fibrosis is seen in about 3/4 of patients on biopsy, and this term comes from the Latin word storia, meaning woven mat. This is also sometimes described as cartwheel fibrosis, where the fibrosis emanates out from the center in bands that can look like a cartwheel, as depicted in the top right image. Obliterative phlebitis describes veins that have been obliterated by immune cells, which is very specific for the disease. It's important to note that tissue IgG4 positive cells can be seen in a ton of different diseases, such as IBD, ANCA vasculitis, rheumatoid arthritis, sarcoma, lymphoma, staph infections, the list goes on. So just having IgG4 cells is not sufficient. And as of 2019, when the ACR, the American College of Rheumatology, published their new classification criteria, there is a way to diagnose without tissue using a scoring system that's primarily driven by serology and imaging findings. Next slide. So most patients have a dramatic response to glucocorticoids, as I mentioned, but based on data in the treatment of IgG4 related pancreatitis out of Japan in 2009, when patients were treated with prednisone monotherapy that was tapered off after 3 months, over half relapsed within a year, and almost everyone relapses within 3 years. So despite this data, not all experts agree that everyone needs a steroid-sparing agent at baseline. Those patients with more limited mild disease could be managed with prednisone only. And if these patients flare, you can add conventional DMARD such as azathioprine. And DMARDs such as AZA, methotrexate, mycophenolate have only been evaluated in observational studies or small randomized clinical trials and have not undergone any head-to-head analysis. But of these, AZA is the best studied. Next slide. Okay, thanks so much.
Michael, thank you. That was terrific. Can you hear me?
Yep.
Yeah. First of all, it was wonderful. The question of that she also had Sjogren's, really bad luck, or is there association between the two? It's weird when it's a mimicker, but you're also potentially saying maybe she had both.
Yeah, I mean, I think that just given her the disease manifestations that she had several years ago, if you go back into her medical history, the ITP, the peripheral neuropathy, the Sicca symptoms with the positive SSA is really difficult to ignore as associated with Sjogren's. I would say all of those things are more associated with Sjogren's than they are with IgG4. So if she just had Sicca symptoms and maybe like a low titer SSA, I would say, okay, maybe it's all IgG4, but it's hard to avoid those other disease manifestations.
Yeah, thank you. Gurpreet, any comments?
I'm so grateful that the patient and their family want us to learn from this, because I think it's a really important disease. I've overlooked it before, so I appreciate the chance to mention that. We had a case years ago where someone was thought to have pancreatic carcinoma. There was as Dr. Tomaschall mentioned, autoimmune pancreatitis is one of the manifestations of it, and it can take a mass-like effect. And the patient went on to have surgery. We sort of have equivocal preoperative data, and then had a Whipple's, and only when the Whipple was done was it clear that there was no adenocarcinoma, but it was all these plasma cells that had just taken on the mass-like form. And I think there's examples in other spots in the body where we can be fooled. And so a case like this where we get to raise our awareness of it, I think is a real gift.
Great. A couple of minutes for questions. Before we do, I just want any reflections on the case and what you learned from going through this particular case?
I think, we talked about sort of the scripts we have in our mind. It really forced me to say, like, which diseases are indolent, which diseases are explosive, when is it enough to call it a disease? I think that was a really interesting exercise. Like, do I accept Sjogren's as background information, or do I reject it? And I think we landed in an intermediate space. Like, it is a tremendous, it was a very compelling case for Sjogren's, and yet we learned about a disease in the end that can mimic it. And I'm holding both of those things in my mind as being true in this case, rather than it was one or the other. Yeah.
Yeah, it's really important, when you hear about the past history, you don't want to drive yourself completely crazy, but you have to say, okay, she had quote unquote blank, probably true, but you always, when there's evidence that doesn't quite match up, you have to at least question and make the possibility that it's something different. And the same thing in a way with the trajectory. You sort of go in with this Occam's idea that, is this a disease that was indolent and has gotten worse, or can I explain this with two separate diseases?
And even I'll just point out, I almost, the pattern of organs was to help me think about IgG4 along with the Sjogren's, but it was interesting for me to note, I thought somehow the infection would be modulated by the immunoglobulin story, and it seems like the complement part of the story is the thing that renders her susceptible to this sort of infection.
Great. Let's open up, see if anybody has questions, and say who you are. Peter?
Hey.
Oh, there you go, we have a real mic.
Hey, Peter Barish, Hospital Medicine. Early on, when we were still wondering whether this was an inflammatory, sort of autoimmune inflammatory versus infectious, one of the first labs we got was a really, really elevated CRP.
Yeah.
And I kind of always in my mind taught that autoimmune conditions can give you an elevated CRP, maybe up to 100, a little bit more, but that if you see in CRP in the 400s, that's really classic for an infection. I don't know if that's apocryphal or if you feel like that's sort of true in your mind as well.
Yeah, I don't think I studied it. I don't think I've internalized that. I think I just thought it was off scale, so to speak. And so I sort of kept myself in both categories. I bet you that makes sense to me. I just haven't thought about it or studied it. I don't feel like I see a lot of 400s or 500s, even for the high CRPs we see.
there one online? Yeah, go ahead, Lakshmi.
Online question from Dr. Ann Fenton. Would you also see the total IgG elevated, or does the IgG4 elevation not influence the total count enough to see that? And how is it possible that someone with recurrent unusual infections with hypocomplementemia not have this detected in a workup before?
That might be a question for you, Michael.
So the first part, the IgG is oftentimes elevated, driven by the IgG4 level, in that 75 to 90% of patients who have an IgG4 elevation. And how was this not picked up previously? You know, when I spoke to her outpatient rheumatologist, she didn't actually have a long history of recurrent infections. So, you know, I think that her care was a bit splintered, sounds like, and he was working her up for IgG4. He was following up some of that prior data that was found when she presented with this incidental liver enzyme elevations. And
Good time for one more? Yeah. Go ahead. Well, I'll repeat it. Just go ahead.
Sure. Did you do a metabolic panel on the cytochrome P450s just to think about chronic prednisone exposure? If you have induction of the enzymes, you can go below the therapeutic window such that if you had a viral infection, you could have the cytokine storm infiltrating lymphocytes and the cell results in exposure.
Did I understand that correctly? You said if the prednisone would lower the lymphocyte level and that would,
Yeah, sorry, just if you would get prednisone long term,
yep.
then you would have induction of the metabolic enzymes such that you get rid of the drug a lot faster, so the steroid's not working as
Oh,
well.
I see. Okay.
And so then you're below the therapeutic window, and then when you have the viral infection to the teacher, then she's not responding in general.
Yeah, I saw.
Take a stab at that.
That one, that's a little, I follow your line of reasoning. I don't know that phenomenon well enough to comment on it. It's plausible. I just don't, I've never thought that one through.
Yeah.
Do you like ancestry or like there's
Like pharmacogenomics, if that was done?
exactly,
Yeah. I don't know if the team would have done that. I don't think it's common in practice with rare situations, exceptions like I know anticoagulation and some other situations we consider it. But I suspect it wouldn't have been done in this case, in my hunch.
We need to quit. Gurpreet, thank you. That was
you.
spectacular.
Thank you, Dr. Sen.
Funky, thank you for putting the case together. Michael, thank you for discussing it. Again, next week we are virtual, talking about COVID with Paul Offit from Penn, talking about vaccines. And we'll also talk a little about oral antivirals and Paxlovid and whatever else is up next week. We'll see you then.